So, welcome back again of your cup of tea or coffee. So we move on to a different topic. If I could have granted that we are not familiar with fungi and fungal infections, you can't say that tropical infections are something that you are not familiar with. The trouble is that you think that you are familiar with. You think you know everything about it. But when you really come across a tropical infection in the intensive care unit, I won't say you don't have a clue, but you're very near to that. You don't have a clue as to how to manage that. So I think it's good that we go all over, and as is normal in this course, we start with a case scenario. 32-year-old male, young people, and that is why we talked about importance. It's a huge public health importance because we have lost a lot of young lads in dengue fever, in COVID, in swine flu, in H1N1, and so on and so forth. That's a huge loss to the national economy as a whole and for their own family because young people get affected by these diseases. And that has got public health importance also. That also goes on to show that the public health standards, you can call them health quality standards, designated goals and global epidemics and all that stuff, they are not being met by the government in power. And that is true. That also is an indicator that how much amount of gross domestic product is being spent on health. So these are all indicators. Tropical diseases are markers of healthcare system of the country, just like infant mortality is a marker of the healthcare system in the country. And that is why tropical diseases have got such huge amount of importance. They are used as indicators of the way in which the government provides healthcare to the society as a whole. So fever 7 days, jaundice 3 days, encephalopathy 1 day. Temperature is really high, tachycardia, tachypnea, hypotension, jaundice, drowsy, confused, disoriented, hyperosplenomegaly because nowadays you people do an ultrasound at the drop of a hat, so we get to know it. And there is swelling as well, ascites maybe. So we label this rather than going wrong because there could be several reasons why the patient can present in this manner. We call that an acute undifferentiated febrile illness. Acute, normally I would attribute acute to less than 7 days duration, but the logistics that we have in this country, because most of these tropical diseases have a rural background, and because in those areas we don't get that kind of services, these patients have to travel to big cities and big hospitals like Medanta and Gangaram Hospital. I have been relaxed with the time when it comes to acute. So it's 14 days. The initial signs and symptoms are overlapping between various disease syndromes. So that's why we have to go for a syndromic approach rather than an etiological approach. And all of these conditions come with high fever, at least in the beginning. And all these conditions are possible. Malaria, scrub typhus, leptospirosis, dengue fever. Now, we grew up in managing malaria patients in our internship, our PG days. But let me ask you very candid questions. How many cases of malaria have you seen in your post MBBS period, let us say, when you've actually managed them? One. So you people are fortunate. Two. You people are fortunate. So most common conditions that you have come across among these in your clinical lifetime. Dengue fever, yes. Okay. And can you give me a ballpark figure? You said dengue. Can you give me a ballpark figure? How many patients survived in your ICU? How many died? Roughly. I don't want acute phase. I want the patient who diagnosed dengue came in. Did he go out of the ICU or not? No, no. As a 100 patients came in, let us say. You said yes, it's most common. So let us say 100 patients. How many survived? How many died? Okay. I published a study quite some time ago, at least 10 years ago. My mortality was 38%. And I believed I really took data. You are going by your memory. So your memory only remembers good things, doesn't remember bad things. They have a huge mortality. They have a huge mortality. If they don't come to the intensive care unit, they are managed at home or on OPD basis or even in the ward basis. If they do not enter into the ICU, then possibly your 90% would have been a right answer. Pediatrics, of course, it doesn't work, but your 90% would have been 100. But among the proportion of patients who need intensive care, mortality is very high. My 38 was probably, my sample size was not adequate. It should have been more than that. Okay, so let us go each one. So since most of you people have not seen malaria, it's better that you get to know what malaria is, because India is still labeled as a malaria endemic country. The basic pathophysiology of malaria is mechanical microcirculatory obstruction. So what is the mechanical thing that obstructs the circulation? The mechanical thing is the RBCs, which have been invaded by the parasites, malarial parasites. And this parasite RBCs, they adhere to the vascular endothelium, and that causes obstruction to the flow of blood, and it can cause sequestration of fluids because of capillary leak, and even thrombosis because of the obstruction in the more distal vessels. In addition to that, you get intravascular hemolysis, and you know when the RBCs ruptures, the trophocytes are released into the circulation, there is a sudden rise in temperature. That is the basic pathophysiology of. So classically we would describe that we have malaria in which one day you have fever, the other day you don't have fever, the next day you have fever, again you don't have a fever. Unfortunately, that is true for Plasmodium vivax, but Plasmodium vivax has by and large been eradicated. Nowadays we tend to get only falciparum, that's why we are seeing them less. But in this falciparum we might get a continuous high grade fever, and the only way it comes down is by using appropriate treatment for treating malaria. But we come across malaria because the patients are just simple malaria, they are severe malaria or complicated malaria. And what do we mean by complicated malaria? Obviously, patients come to the intensive care unit because they need organ support. That is the sine qua non. And that is why they come. So organs are involved, organ dysfunction is there. So they would be comatose. They are having anemia because of hemolysis that is undergoing in the intravascular system. There is hypoglycemia because the liver is not working. Most common organ involved in this kind of case is the liver. And neoglucogenesis is the one which is affected. So the liver is not able to form more sugar or more glucose in the presence of fasting or decreased nutrition. So if we have hypoglycemia, because of the fluid loss, sequestration of fluid, and because of the obstruction at the distal vasculature, we have metabolic acidosis. All these things lead to acute kidney injury, and which might involve the lung to produce ARDS, shock, DIC, hemoglobin in the urine, and all this happens because of the high parasite index, and I'll not talk too much about it. Usual diagnosis microscopy. In my days, all the medicine wards used to have a microscope, and we were taught how to make a thin slide and a thick slide and see it under the microscope, and we would see with our own eyes what it is. And this is what we used to see, an RBC invaded by the trophocyte. And in that, we became so good that we could even say that this is Vivax. But nowadays, these things are denied to you because you people are now fortunate enough to travel on Ola and Uber rides, and we have to go by DTC buses. So you're fortunate people. What can I say? But then there are other things which have come in. As I said, you are fortunate that you are getting instantaneous reports. Put it Google Baba bolo kya hai, chat box bolo kya hai, and you get the answer. So this is quantitative Buffy code cubic state. It is faster, more sensitive. Species quantification is possible. Species identification is possible, but it needs specialized equipment and consumable, but it's more expensive. National Infectious Disease Control Center in the north of Delhi was the first time it was installed there, and now vector control all over, wherever they have the laboratories, they have this thing available to them. AIMS, and my hospital doesn't have it. I don't think Vedanta has it. But what has happened in the peripheral hospitals like ours, we go for rapid tests for detecting malaria. And these rapid tests are based upon antibodies to malaria. We have antigens available to us in the lab, and we put antigens to the blood sample that we get from the patient, and if the patient has produced antibody, then these antigen antibodies react to each other and you have a probable diagnosis. Of course, due to UV light and other things, we will not talk about it. And we have seen that these rapid diagnostics tests are almost as good, 90% sensitive, 90% specificity, and reasonably good. You don't have to go for that quantiferon kind of test. What's the drug of choice? Artesunate. We were taught chloroquine in our good old days in childhood. Chloroquine is gone because Vivax has gone. So we are moved on to artesunate. The doses are something that you can look up, but we add doxycycline to the patients. The duration is a minimum period of 7 days, and we shift to oral drugs as soon as possible. But I do remember in my internship days when we were coming across falciparum malaria, we used to give 600 milligram of quinine dissolved in 5% dextrose to given over 6 hours, and 3 doses of this were given. And that is a classical, and even now it works. But nowadays we add doxycycline in addition to quinine or artesunate. Clindamycin would be used if there is contraindication to the use of doxycycline. Doxycycline, remember, is a tetracycline. So any contraindication to tetracycline, you cannot use it. You use clindamycin in those conditions. Okay? Scrub typhus. Now we really need to give tribute to the Professor Dhruv Chaudhary, the professor of intensive care and pulmonology in Rohtak, to bring to the map of the world that scrub typhus is perhaps the most common tropical infection in this part of the world. In this part means Rohtak, Haryana, Gurgaon, where they felt that among all the tropical fevers, the incidence of scrub typhus was very high. What is it caused by? It's caused by rickettsia, an organism called Orientalis suzukameshi. And the vector is chiggers, which is the larvae of trombiculate mite. And the chiggers are actually the reservoirs. There is cycle is between rat and mice and so on and so forth. Humans are accidentally involved when human beings act like rats and go into fancy caves and water and those kind of situations, or trek, for example, on barefoot. So those kind of conditions, they get accidentally involved. So rickettsia do not have any toxins, but the organism, the larvae of trombiculate mite, it's itself cytotoxic, and that is why it produces direct endothelial injury, and it produces what we call today as the HLH syndrome secondary to sepsis, and that is why these patients go into this organ dysfunction and even death, and they need to go for some specific or maybe high dose therapy or plasma exchange, those kind of things, immunoglobulins, IVIG is given in this phase. So clinical features: incubation period 1 to 3 weeks, sudden onset, fever, headache and myalgia, very quick involvement of the CNS. So the patient might have delirium, nausea, vomiting obviously is there, but there is a maculopapular rash, and this maculopapular rash is centripetal in origin. That means it starts from the areas which are covered by your clothes. So maybe your pants and shirts. So it starts in the groin, in the trunk, and thus goes into the limbs, the legs and the arms. So that's why generally speaking it is hidden. Unless you undress the patient, you don't get to see. And if you're lucky, you would get to see this eschar. And this eschar is a pathognomic of scrub typhus. The moment you see this eschar, you can straight away start this patient on doxycycline. And this is, as I said, the site of eschar. To begin with, it is confined to the central portion of the body. Then it goes into the periphery. And that's the clinical course. You see in day 1, day 2, the temperature is not high, everything is not high, but you can make a diagnosis by lymphadenopathy, by rash and eschar. Eschar comes very early. So if you're fortunate, you can see this eschar. You don't have to bother about making a diagnosis. Straight away start this patient on doxycycline. And if the patient responds, that is your diagnosis. Patient has become better, who bothers what is there in the blood? Let the patient take a course of doxycycline, send him off home. So it is that pathognomic. But as I said, we big hospitals are built because we tend to get the referral from all these patients, and we get referral when these patients going for organ involvement or organ dysfunction, which could be brain, the liver, thrombocytopenia. Not very common in strep typhus, let me tell you. Even if the platelets come down, they tend to be around 100 or so. So that is one of the reasons where you can suspect strep typhus over a dengue patient for that matter. Okay, the patients can obviously have other organ dysfunctions like AKI and shock and fetal loss. So when should you look for strep typhus? Pathognomic SCHAR, as I told you, and evidence of multi-system involvement, liver, kidney, thrombocytopenia, the coagulation cascade, leukocytosis. We talked about leukocytosis, and we'll be talking about those conditions where we'll have leukopenia. We talked about fungal infections producing leukopenia. What other conditions would produce leukopenia? Viruses. Viruses. So it is not bacteria. So virus, dengue is a virus. So that can produce a leukopenia and thrombocytopenia, profound thrombocytopenia in that condition. Wheel Felix test is a poor man. Nobody does it nowadays. A lesser mortal would do it, so it's out of the window. But immunofluorescence assay would be the gold standard. But what we do here in strep typhus is ELISA for IgM for strep typhus. There was a time when I started, way back 20 years ago, we used to send samples, blood samples to NCDC lab in north of Delhi to make a diagnosis of strep typhus. Fortunately, this IgM is available in my hospital now. I can make a diagnosis. As I said, doxycycline, 100 milligram BD, 7 days. Leptospira. And leptospira is disease of the monsoons, season of the rainy seasons. This is when you get TVs, newspapers showing roads full of water, buses halfway submerged, the drain water overflowing, people walking with barefoot. That is a stage set for leptospira, the most widespread zoonosis in the world. Peak incidence in the rainy seasons could be due to occupational, recreational exposure, and the source of infection in humans is direct or indirect contact with a urine on an infected animal. The portal of entry would be an abrasion or a cut or some kind of wound in your lower limb, and you're wading through that water which is infected by rat urine. So we have a biphasic presentation, clinical presentation. The first phase is the bacteremic phase, in which you get the normal headache and fever and body aches and so on and so forth, dehydration. This is what you get in the early phase. Then the body mounts an autoimmune kind of response, and you get uveitis, chemosis, conjunctivitis, joint pains, which is different from muscle pain that you were having in the beginning. So the pattern changes. So you have a biphasic clinical phase, and then only 5 to 15% of patients have jaundice. Not very uncommon to see jaundice and dengue fever for that matter, but very little, rarely 5 to 15 patients would get what is called as leptospira icterohemorrhagica, which is the Weil's disease, in which there is jaundice and there is AKI. There could be pulmonary hemorrhage, and that pulmonary hemorrhage could be so intense that it could well be a terminal event in that patient. So this is where, so don't think that these tropical diseases are innocuous. They can lead to death. These patients can have rhabdomyolysis, and that's why they can have CPK levels which are very high. Cultures generally come as negative, but serology is what you have to look for. You go for microscopic agglutination test, MAT, or you can have slide agglutination test, which is called SAT, which are reasonably good in sensitivity and sensitivity, but still you should remember that sometimes, more often than not, the diagnosis of leptospira can be difficult. You can see fever is biphasic. Initial first week there was fever, it recurs again in the second and third week. What you see, the antibiotic titers, they are negative in the first week. They only come up in the second week. So you can't make a diagnosis until 1 week has gone by. And during that time, so many quackers have already had their sway, and they have prescribed all kind of antibiotics to the patients. So antibody titers may not be detectable. But blood cultures and CSF cultures could well be negative. So diagnosis is difficult, and it is only possible in the second week, in which case the patient has become better, he will not be compliant to your wishes, he will not do what you are telling them. So that's why more often than not we miss leptospira, because we don't wait long enough for the diagnosis to become apparent. So that is a problem with leptospira. Antibiotic therapy is required because it shortens the time of convalescence, but everything works. Ceftriaxone, penicillins, cephalosporins, even doxycycline, everything works in this case, so that's not an issue. So we come to dengue fever. Belongs to the family Flaviviridae. Is it a neurotropic virus? My question, anybody can answer. Is it a neurotropic virus? If it is not, can you tell me one neurotropic virus that you can think of? Wow, have you seen it? Tell me something which you have seen it. Japanese encephalitis, excellent, very nice. Herpes, herpetic viruses, that is a neurotropic virus. Dengue until now was labeled as a non-neurotropic virus, but we have enough case reports, especially in the last dengue epidemic, to say that we had central nervous system involvement. Whether that central nervous system involvement was directly due to the virus or due to an autoantibody kind of a response in the central nervous system, we don't know. But there are several reports which have come in the last 3-4 years. You can look up in the Google of CNS manifestation of dengue fever. And if you look up the MRI images, dengue fever MRI, you can get the classical dumbbell pattern of which you normally would see in a chronic liver disease patient, for example. But dumbbell pattern in the MRI. So if you Google dengue imaging MRI, you will possibly see dumbbell pattern, something like 2 basal ganglia on either side of the lateral horns. So neurotropic manifestations are also very common, though they are not described as such. So it could be secondary due to other infections. We have known by experience, we have known that if you have had dengue once, the second time if you have dengue, you generally end up with organ failure. You end up with the ICU. And the reason is that the antibody to dengue fever that was formed by your body, that cross reacts with the present infection antibody, and that mounts a surge kind of response, which can lead to a surge or a cascade of cytokine and complement activation, can cause endothelial dysfunction, platelet destruction, consumption of coagulation factors, plasma leakage, and hemorrhagic manifestation. That is why, lady, all these problems make their mortality very high. So you are probably doing work in the wards and not in the ICU. If these are the complications which happen, and we tend to get repeat dengue infections, and we tend to get them in multiple organ dysfunctions, and despite all our efforts, despite very aggressive fluid therapy, colloid, crystalloid blood and platelets, which normally is not recommended until the platelets really become too low, patient really bleeds, then only we transfuse them with blood, still we tend to lose them. And what do you see actually? What do you see is that patient is transferred to us because the doctor thinks that the patient has become very sick. He transfers the patient to us. The patient arrives to the intensive care unit conscious. He is coherent to all your questions. Appropriate answers he gives. But when you touch that patient, he is just not cold. He is icy cold. And by the time you put the central line into this patient, the time has come for the patient to become almost comatose. You intubate the patient, aggressively resuscitate the patient with everything that is under your disposal. You don't save these patients. That is what is called as dengue shock syndrome. But these are the various syndromes that you come in dengue fever, undeficient fever, or the standard it could be dengue hemorrhagic fever, it could be dengue shock syndrome. So the classical presentation of dengue fever at the OPD basis would be fever, headache, muscle and joint pains, nausea, vomiting, very, very common, very, very common. Rash, and rash, as you can see, it is not the rash that I showed you for scrub typhus. This rash is a purpuric rash because of splinter hemorrhages occurring underneath the skin, and these are again in the central portion of the body. So these are hemorrhagic manifestations. Sometimes you get conjunctival suffusion, but these could be labeled as warning signs. So these are the usual things that you're seeing. You get leukopenia in this patient because it's a viral infection. So these are standard things. But if the patient presents with these warning signs, like abdominal pain or tenderness, that means the liver is getting enlarged, the liver is getting enlarged. You will see from the ultrasound the liver would be 17, 18, 19, 20 centimeter. Could be having splenomegaly as well. So persistent vomiting, clinical fluid accumulation, you will see ascites in your ultrasound, mucosal bleed, nose, eyes, liver enlargement, and there is a hematocrit which has gone up to 50, 55, even 60. Why does that happen? It happens because of hemoconcentration. That is why the hematocrit is curiously high, and then day 1 I see a hemoglobin of 16, 17. Day 2 I come back in my rounds and I still see a hemoglobin of 15, 16. You are not qualified to be my registrar. What kind of registrar you are if you have not been able to get the hematocrit down from 16 to 12 in 24 hours. 24 hours is enough time for you to volume resuscitate this patient. Okay? So this is the way dengue works. The problem is that patients are managed by and large outside of ICU in the first phase in which the patient is having fever. During this time, again, diagnosis is difficult. The IgM, IgG antibodies of dengue are not positive until the first week is over. So during first week, we go for an antigen, not an antibody, which is NS1 antigen, which might be positive on the third or the fourth day. We don't make an early diagnosis, it's more of a clinical. More clinical, the most important being cause dehydration and history of fever. That's the only two things that come up. And then subsequently, the second week is the period which is a critical phase in which patients land up to us with organ failure, and this is where, despite our efforts, we do not make a good outcome of ours. It doesn't present a good outcome. So these are dengue hemorrhagic fever, in which you have the hemorrhagic manifestation, capillary leakage is there, and this hemorrhagic manifestation could involve the skin, the oral cavity, it could be gastrointestinal, hematuria, and in females it could be increased periods. And then we have the dengue shock syndrome that I have alluded to time and again, in which we have the dengue hemorrhagic fever criteria plus evidence of circulatory failure, severe hypotension, refractory to vasopressors, and these are the cold and clammy skin. How do you distinguish dengue from scrub typhus? Dengue fever generally have overt bleeding, and even though scrub typhus patient would have thrombocytopenia, it is not to that extent that it would produce spontaneous bleeding. Rare, not that it will not happen, but relatively rare. If you are seeing hemorrhagic tendency, if you are seeing over bleeding, even conjunctival hemorrhage for that matter, likely dealing with dengue fever. And of course, you have to go by what is happening in the community. If the community is reporting cases of dengue, obviously you are dealing with the dengue patients. Leukopenia, as I told you, it's a viral infection, and viral infection would produce with leukopenia. Tuberculosis would be one differential diagnosis that you have to keep in mind. Severe thrombocytopenia, 10,000, 5,000, 7,000 platelets. You don't get that kind of thrombocytopenia in strep typhus. So bleeding is what differentiates strep typhus from dengue fever. IgM, as I said, is positive from the second week only. No specific treatment except resuscitation with a judicious mix of balanced salt solution, albumin, blood, colloid, FFP being used as colloid. Don't know, I leave it to you. The colloid and crystalloid debate can go on. But yes, avoid drugs which can have an effect upon the coagulation system of the body, like aspirin, non-steroidal. So you have to give something to bring down the fever, use paracetamol only, no NSAIDs. So to conclude, you can see all these patients come with certain denominator which is common to all of them: fever and multiple organ involvement. They may not, most of them do not have, but the patients who come to you are referred to your ICU, are referred because of multi-system involvement, and that is why you have to keep this in mind. The distinguishing clinical features which will prompt you in making a diagnosis is Eschar in case of a strep typhus, conjunctival suffusion, splenomegaly, overt bleeding manifestation in dengue fever for that matter. Lab diagnosis becomes very crucial, and you should know which is the time period in which what is likely to be positive. As I said, NS1 is good for the early part. 1 week later, maybe IgM would be positive. 1 week later, you will get IgG also. Importance of IgG is important. That would tell you that the patient had a previous infection also. A second hit with dengue fever is likely to be more dangerous than the first one. Management, generally supportive therapy. Obviously, leptospira is a bacteria, so it has an antibiotic, but otherwise it is supportive therapy. IV fluid management is crucial in the outcome of this patient, and I really thank you for your patient listening.
Thank you, Dr. Shastri, for nice talk.